Stolley, and I serve as the chair of the Wisconsin Cancer Collaborative. I'm the professor, or a professor, I should say, and associate director for cancer prevention and control at the Medical College of Wisconsin. And I'm just so thrilled to be here. I was so worried that the summit wouldn't happen, but I'm delighted we're all here together, that you've all made the effort to take time out of your day to be here. And we have a mix of new and familiar faces. So it's going to be an exciting day. Purpose of the day. I do want to say, if you need any assistance, you can change your name, right? So that we can see who you are. So just change your name to include your first and last name as well as your organization. That would be terrific, and that way everyone can see who's on the call. I'll leave this up for a second for you to be able to see. In fact, I will. There we go. Okay. Okay, next slide. Great. So just to give us all sort of some framework and structure for the day of what we hope to accomplish. First and foremost, coming together. It's great that we're all here virtually. It's too bad we're not in the Dells, but we are in one screen all together. We want to be learning from our partners, listening and exploring ideas on how to achieve health equity, the new first chapter of our state plan. And then we're going to have a terrific day really understanding and learning more about the new Wisconsin Cancer Plan and the role we all can play within our organizations, within our lives, to reduce the cancer burden across the state of Wisconsin. Next slide. So first and foremost, I'd like to thank our steering committee. This is a group of really devoted, committed individuals who come together on a regular basis that helped guide the selection of speakers for this and the programming for our summit, but also contributed greatly to the development of the state plan. I also want to thank our membership for their contributions to the final state plan. And none of this could, next slide, please. Actually, you know what, before you slip slides, I'm sorry, go back if you don't mind, thank you. I do want to call out names though. So we have Sandy Bernier, Chris Scrooge, Judy Hoibel, Gail Johnson, Kim Kinner, Dimitri Mills, Annika Moore, Laura Pedersen, Paul Silha, Nancy Seidner, sorry, I always struggle with that name, Lanya Stens, myself, Regina Vidavar, Mark Wegner, and Angela Worry-Acton. Really such tremendous work through this committee. And we can't do any of what we do without the tremendous staff at the Wisconsin Cancer Collaborative. And I love this slide because it has all the faces of these committed, intelligent, happens to be all women, just a coincidence, and how great the work they do to support all that the collaborative does. Next slide. All right, so our agenda today, we've gotten through the welcome. From 12:10 to 1, we will have Dr. Lisa Richardson speaking. I'm so excited that she's here. I've known Lisa for decades, and in fact, I think of her as a mentor in the work that I do. Then there'll be a short break from 1 to 1:05, and then Sarah will be leading us through an overview about the cancer plan. And then there'll be a general session panel, sort of breaking down the panel, another break, and then we'll be doing discussion breakouts by the plan chapters and closing. So we'll be done at 3 p.m. Next slide. So now it is really my great, actually, I'm sorry, you guys, I'm not used to doing this virtual thing. Before we introduce Lisa, I do want to say that we have today and we have tomorrow. So you all have we'll see the agenda tomorrow. Hopefully you all got your little goodie package in the mail. that had the plan, but also the little notebook and the pen. If you have questions, please enter them in the chat box. Beth Bruno will be monitoring that chat box. If you have any questions or technological problems, you can put those in there as well. And if at any point during the day something happens and we get shut down somehow, just stay on, and we have tremendous capacity for addressing any technological challenges. So now it really is my great, great honor to introduce Dr. Lisa Richardson to give our keynote presentation this year focused on health equity. And Dr. Richardson has held numerous leadership positions within the Centers for Disease Control and Prevention in her more than 25 years of public service. She's really a tireless champion for change. She breaks down systemic barriers to good health. And what's so cool about Lisa, what I love, is that she's really this wonderful combination of data enthusiast, she's a medical oncologist, and she's true boots on the ground energy and passion. She's authored or co-authored more than 150 peer-reviewed journal articles. She's examined, and within her work, she examines multiple sector approaches to improving cancer care access, delivery, and outcomes, really from that whole cancer care continuum from prevention to end of life. As the director and sort of convener in chief for CDC's Division of Cancer Prevention and Control, she has been, I use this word champion again because it's true, of cultivating new thinking, new programs and partnerships that really improve the opportunities for all people to be healthy and thrive. And I'm just so delighted that we have her here because I think her perspectives, her experience, and her wisdom will really be of great value to all of us, and thinking about how we take some of what she's done and integrate it into our work. Lisa, thank you so, so much.
Got to unmute myself. Thanks, Melinda. And thanks to Sarah for inviting me months and months and months ago. But I'm really, really happy to be here. And thanks to Melinda for saying that I love data, and we can't do our work without it. And I just love talking about it. And we also love collecting it at CDC for us all to use. And so I just want to thank you for having me. There'll be some different topics mixed in with, the equity as we go along. But thinking about, it says leading through uncertainty. And I was actually thinking this morning as I was preparing, is struggling to lead through uncertainty, right? So we're all struggling to try to figure out how to lead, how to stay focused during this time. Next slide. So I think one of the side effects of the pandemic may be that we may lose some of this progress that we've made since 1999. Cancer death rates have dropped 26%. This is actually, we released this in June when the new death data became available on our website, but we are really have made a tremendous amount of progress. And most of this progress has been through prevention efforts, such as decreasing cigarette smoking. So we have made progress and we want to continue, but we'll talk a little bit later about where we might, run into some issues with the pandemic. Next slide. So I think we're looking here at the cancer death rates. You can find this on the CDC website, or DCPC, but you'll see that progress is not even. Everyone has not, benefited the same. And I think what may be a more telling measure is survival, which I don't have here. And almost every group has lower survival than non-Hispanic whites. And that really is a combination of the stage of disease, the treatment, where you live, all those factors that Melinda mentioned earlier, the socioeconomic factors. Next slide. And so here, this is our, some of you have seen this. This is our one page, one slide strategic priorities. And so when I became director, it's hard to believe it's been 6 years. 6 years ago, we came up with a strategic plan, which is really a prioritization process. It's really not a plan. And so, the places we can lead is really where we concentrated, building from the bottom up for what you see here. We want to be the go-to for data, same as you guys do in Wisconsin. We want to translate and evaluate what people are doing, translating and evaluating in real time. We've done that with our colorectal cancer control program specifically, and partnerships. And as you know, you can't do this work without multiple partners in multiple sectors. And so, and then as you work your way up, you'll see equity is one of our guiding principles. No matter what we do, we should be addressing equity. And then in the work we do is prevention, risk factors, screening, and improving health and wellness for survivors. Um, and that pretty much that's a lot right there on one slide, but that's pretty much what we do. Next slide. And so you all are familiar with, some of you are, with our structure in DCPC. We have 4 branches and the Office of the Director, and you'll see there each program with its, which is within each branch. And so it really has been like when I came on 6 years ago, really couldn't tell why. Really didn't see a need to rearrange things. We have made some within branch rearrangements and changing around of staff, but things are pretty much the same. It's one of those things, if it's not broke, why are you out there trying to fix it? So I still think it works really well for us, the structure we have. And if it needs to be changed, we know we'll look at that and take care of it when we need to. Next slide. Again, the 4 big programs are foundational. The meeting we're attending today is the National Comprehensive Cancer Control meeting, excuse me, the Wisconsin Comprehensive Cancer Control meeting in Wisconsin. But the 4 programs should be working together, collaborating and coordinating across the 4 programs where they exist. The CRCCP is not nationwide. We now have 35 grantees. We just re-upped that one. But we're trying internally at CDC to model the behavior that we want to see. So the next notice of funding opportunity for the 3 programs should reflect our wish to do more of what you do, collaborate within the state, collaborating across the branches and the programs at CDC. Next slide. And so in our current iteration of the Comprehensive Cancer Control Program, there's 50 states, 7 US territories, and 8 tribes. And these are the things that we work on specifically. As you know, these line up perfectly with the division priorities, and with health equity being one of the pillars in comprehensive cancer control. Next slide. So who are the partners? So this is based on the information that the Comprehensive Cancer Control Program send us in CIDMIS. This is information that we pulled out of the information management system to sort of see who are you guys working with. This is a couple of years old. I guess we could do it again now that we have a year and a half, 2 years of experience in the next go. But I imagine it hasn't changed very much. And so what you see here are academic the universities, business, professional associations, policymakers, big P, those are your people at your government partners as well as others. And what I see, here for me when I'm looking at these partnerships is that we do have partnerships with professional organizations, but not with insurers. And that really is, where the rubber hits the road. Who's going to pay for care? How do we get care paid for people who lack access and lack health insurance? But the programs pretty much work. And I'm sure out of the 100 people, I think I saw there's about 100 people online right now. I'm sure every group is represented here. Next slide. So what's new with COVID-19, looking at COVID-19 and disparities? Next slide. So who is at higher risk? Well, it's just like everything else in life. I guess none of us can escape getting older, but really people over 65, and I would say it's probably lower than that. People under 65 with multiple chronic conditions or other conditions, health conditions, are at risk as well. So it's not just older people. It's people with cancer in particular. We finally got that one finally convinced CDC to put that one on the at-risk populations and to call it out, not just list it under immunocompromised. The data out there show that people with cancer or who have experienced cancer are at higher risk for getting COVID-19 and being hospitalized. But how many of us know patients or people that we know who have almost all of these conditions and they are super high risk? Next slide. So this, I think, is one of the things that nobody people talk about job loss, but they don't talk a lot about the consequences of job loss. So here through June 2020, this is the latest information I could find. There are 7.7 million newly unemployed people who lost their health insurance because they lost their job. And, when we look at their dependents, that number doubles to about 14 million with dependents who are uninsured. So there's a whole new or a large number of people out there who don't have health insurance anymore. And we have to keep that in mind as we're looking at the programs we run in comprehensive cancer control, the BNC program, and others. There's a whole new set of people out there that need us and try to rejigger what we do to reach out to those people, or redesign, I should say. Um, Next slide. And our clinical partners, these are the federally qualified health centers. I know you guys work with the health centers quite a bit, the same as us at central office. And this is what they're telling, this was as of September 25th. They've been surveying their clinics. HRSA has been surveying clinics on and off during the pandemic. And you'll see that they are, doing virtual visits, probably not as many as they would like. The health center visits are lower, 83%, but the real challenge here is that the health center staff are getting infected and not being able to come to work. So in addition to, the patients being sick, the providers are getting sick with COVID-19 as well. You can't come to work. And the thing that's not on here is, all of these people, or some of these people, probably have relatives, children for whom they have to stay home and take care of, teach them. Anybody on the phone with children who take care of kids and are school teachers now, I admire you. I'm not quite sure I would have been able to do that task when my son was smaller, because it's a huge job and you're expected to continue to work. And the other thing, there's about 1,000 clinics have closed, at least temporarily, and some of them may close permanently. Next slide. So in the work we do at Cancer Control, we rely heavily upon the primary care specialty to help us get our work done. And so what they've noticed is that it used to be a weekly survey. Now it's about every other week to every 3 weeks, where they actually survey primary care providers of all type. And so this is what they report. In the last report, the thing I found significant here was that at least 41% of them thought that their patients with chronic conditions were noticeably worse, not coming in for visits, blood pressure not controlled, diabetes. And these are people who had previously been doing better. And they furloughed their staff. Many of them have not been paying themselves and their other workers, and 7% aren't sure that they'll last past the end of the year. So when we lose these providers, they're gone I believe they're probably going to be gone forever. And primary care is still one of those specialties that's having a really hard time recruiting new people to come into work. And way over half of the primary care providers surveyed are mentally exhausted, probably more so than we are. They don't have the PPE they need. They're not getting paid. They didn't, that loan repayment thing in the CARES Act, very few of them got access to that money. So they are really, really, really struggling out there just to keep their doors open. Next slide. So delay and avoidance of care, I mean, this is, undoubtedly one of the huge issues out there. People are just dying at home. There's been a couple studies out there of where did all the heart attacks go in the emergency room? Well, a lot of them just stayed home and did not come in for care, and probably died, at home from those conditions. And so a third are avoiding routine care. These are the things that we're concerned about in what we do, people going in for their screenings, their weight management, diet, diet and exercise, counseling, those things have pretty much just not been happening, not in person. There's been some um, uptake on the telehealth side, but it probably has not been um, equal to what they're missing in person, is what I've seen when I've read the literature. Next slide. So this is a really, really dramatic example of the impact of the COVID-19 on services, such as the stuff we do, cancer screenings. So this is as of July, I think July 17th. I haven't been able to find anything more current than this. It is coming back up, and you see it's almost back up to baseline, but people just closed down. Every hospital's closed. People stopped coming in for care because they were afraid. I think what the last numbers I read, it was about 30, 30, 30. Don't know, 30% it was the patients, 30% it was the provider, and some of them we couldn't answer the question as to why people didn't come for care. But um, next slide, and you'll see some of the consequences of not coming in for care is that within a health system that published their data, you'll see that the number, this is an example of colon cancer, the number of colorectal cancers diagnosed, was halved by April 12th between baseline the year before. So people have cancers that are not being diagnosed. Um, I believe people are out there with symptoms that they aren't bringing in to their providers because they're scared of the care setting. And so one of our priorities at CDC we're working on now to be shared with everyone is what would be a campaign, not really a campaign, I don't like those things. What would be like some messaging that we could put out to help people navigate the decision of whether to come in for care or not? Because at the end, they have to decide on their own. Um, but one of the things that we're thinking about, one message is cancer doesn't wait, and neither should you. And one of those things there is that if you took that where you are in Wisconsin, you could add your own bit to that and sort of personalize it. But really, cancer doesn't wait, and it's going to be. I think we're going to have a long haul trying to catch up with all the things that haven't been done in this pandemic. Next slide. So this is some data from, let me see, where did this come from? I can't remember. But anyway, what you see here is excessive deaths from, and this is only breast and colorectal cancer over the next 10 years, that there would be an excess of 30,000 combined of those two cancers. So this is not looking at all the other cancers, cervical, which there are very few deaths, but they still, are important. And lung cancer, those are the ones that we can screen for. But it's not just screening. People had stopped, hospitals had stopped surgeries. Most of the time, I've heard that the cancer surgeries continued, but there were some, cases where they did not. And then the intravenous chemotherapy and those types of things. Next slide. And so this is just something that looks at the rebound in outpatient care visits. So these are general visits, all visits, which is back up to baseline, as you see in July, but now it's back to zero. So people are on a national level coming back in for care. And these are claims data. So in the places I was talking earlier with some of the people that that are doing, Melinda and Sarah, about what you guys are seeing in Wisconsin. So this is more or less a national look. The interesting thing with COVID-19 is that you have to be, it's very localized in communities and states. So what may be going on in Georgia might not be going on in Wisconsin, though I think we're both in the same group now with, the infections going up, but it's almost community by community, depending on who lives there. So that makes it even harder for us, to give recommendations on a broader level. Next slide. And so from that same paper, and the reference is at the bottom if you want to go look at it, you'll see here that the oncology visits have pretty much gone back to normal. Some have rebounded, a lot, like the dermatologist. Not sure what that's about. And this one, this study is a little bit different than the last one, shows that adult primary care has rebounded as well. And these are in-person visits. So but a lot of people are not coming back in. And a lot of these are being done with telehealth visits, but there's not 100% replacement with telehealth. So we see people are not receiving care who probably would have previously. Next slide. This is the elephant in the room is mental health. Um, we were struggling to make mental health a priority before this happened with COVID-19, but just from looking at this, looking at the last row as an example, severe depression has increased threefold, fourfold, and people are just struggling, at home with the new setup. I know I struggle with it because I like to be with people. And it's been a long 9 months for me, or close to 10 months now. I guess we're getting there. So I do understand, and some of you all may be experiencing this as well. Relatives, getting COVID, people are passing away with the number of deaths that have been recorded. Most of us probably know someone, or at least know of someone who's passed away from COVID-19. So the mental health issues are huge. And these are things that, excuse me, we're going to have to deal with into the future. And I think our survivors are struggling even more than the general population. Next slide. And this is just a very high level look at anxiety and depression nationwide. You'll see that the highest numbers are, up to 55%. Georgia is in that 55% range. So there's a lot of people out there that need help. One of the underlying issues we don't talk about, and you guys may talk about this in your coalition meetings, is that the opioid epidemic is worsening because people are isolated and are, depressed and feeling hopeless. So we got several issues in an issue going on. And one of the things that it shows, next slide, is that our healthcare system, and maybe our public healthcare system in particular, has just been decimated over the last several decades. And we haven't been able to respond as well to this current situation. So the surge in new cases, you guys probably have seen this on the website. I can't remember what the new cases are nationwide. 8 million, probably it's close to 8 million now, or more than that, but just a snapshot of it, to show, the 7-day average is going up, and it's going up in the nation. I think we've broken new case records here in the last few days, over 70,000 new COVID cases per day. Next slide. So your governor has put in place a stay at home. Not sure if it has teeth. You guys can let me know. Teeth to the order, but even the Packers stadium, Lambeau Field, is not allowed to have people at home games, and I'm sure that one's messed up a lot of people. You guys are the most rabid football fans out there, but it really is about staying home as much as you can, wear a mask, wash your hands, and get your flu shot. And just don't do things that aren't necessarily necessary. That was kind of duplicative, wasn't it? But anyway, but there's just a lot of things we can do to help ourselves through this, and to help others. The message I give is that you wearing a mask is going to protect other people around you, not just yourself. And hopefully that will motivate people to be more careful. Next slide. So, the news is that there's differences by race, ethnicity, there's differences by sex, gender. Men are more affected than women. Minority groups are more affected than others. Next slide. So this has been in the news, as you know. So, why do disparities matter? This is just in general. We die of cancers that are curable. People die of preventable things, diagnosed at late stages, and this is going to get worse. The late stage issue is going to get worse. And I do believe that the deaths will increase from cancer, and we'll probably see it at the end of this year, depending on, what we can discern once the death data is available early next year for this year, especially to see what cancer has to offer. And another disparate place we have is pain control. One study showed that with all the new pain guidelines that came out from CDC, oncology patients are suffering as well, as everyone else, because when you tell persons like me, a doctor, to be careful, we sort of put the blanket thing on it, and oncologists are prescribing fewer um, opioids at the same percent decrease as primary care. Still a little bit higher because cancer patients use more, but still there's another issue of disparate care, that people who really need medicine are not getting it. But that's always what happens. We always overcorrect when we get these edicts from different places. Next slide. So how the pandemic deepens the disparities, as I said earlier, this, I'll let you guys read this for yourself, but there are different areas of disparity, no matter where you go, different way of things are, outcomes are different. I think this was before, during the pandemic or before the pandemic, this is what we saw. Um, and as always, we have to continue to work on the problems that we have. And now they've just been magnified, and we can feel a little overwhelmed. But I think wherever we are and wherever we work, we have to stay focused on what it is that we're here to do and try to help the people that are within the control of what we have. Next slide. Again, the things that people need to do or to do themselves are harder and harder to do, especially in low income environments and the physical environment. We're told to stay home. So, what do? You lost your job. So, how do you pay your rent? How do you do those other things that you need to do to stay healthy? So, this whole thing has just been a real challenge globally. And you all probably know that, and hopefully we'll get some questions later and we can discuss that about how are we going to overcome some of these. Next slide. I won't go over this, but the continuum of care really is, it's everywhere we go. The prevention, the new cancers, prevalence, everything is impacted by the pandemic. Next slide. So COVID deaths and by race and ethnicity. Here we see that the deaths are, hospitalizations are higher for racial and ethnic minority groups. The cases are higher, the hospitalizations are higher, and deaths are a little bit higher. African Americans, it looks like it's twice as high. But one thing that's missing, well, it's not just one thing that's missing from this. This is just a counting of numbers. This is not controlled for all those socioeconomic factors that we talked about earlier. So the studies that have tried to go in and control for those factors of SES, which are hard to get because they aren't collected, the way we need them to be collected, or standardized. But once you start controlling for all of those factors that, low income, insurance, all of those things, the deaths don't seem to be a problem, but the hospitalizations are still a problem. So basically, when you control, you're taking away those factors that might lead to that outcome. And then if you look at just the pandemic, but it's still the same story, right? People are dying from things they should not be dying from because they don't have access to the things they need through the lifespan. And this is really a lifespan issue. This is not, if kids don't get the right food when they're kids, or the moms don't get prenatal care, that whether some people don't believe that, but it impacts your entire life as you move along the continuum, from being born to the end of life. Next slide. So this is really cool. This is something that we did, the 211 hookup with cancer control and other groups was done with a project funded by CDC, I don't know, maybe 20 years ago. So it's been a long time, but this is how you can see what the needs are in your community. And this is the 211 system, and there's a dashboard where you can look at all the things that people are asking for through the United Way 211 number. And so we highlighted food here. And so the biggest need of the 13% of people that needed food assistance, they were looking at 75% were asking where the food pantries are. So this can give you on a higher level, some of the looks at for housing and shelter. I think it was about 40% of people were looking for rent assistance. So you can sort of look at this dashboard of the 211 counts to see what the needs are. And this could be another way that the coalition could work together to sort of figure out where the needs are, who needs it, and how you could go to meet those needs or provide those resources in the areas that you work in. But this is a really neat, I think 35 states participate in 211 counts. So you can just go there and look this up to see what's trending, and it changes based on changes from week to week, depending on what people are calling in and asking for. This is an almost real-time database. Next slide. So what are we doing to address these challenges? Next slide. So not going to spend time on this. You guys have seen this 1,000 times. Every time you apply for money from CDC, these are the comp cancer overarching priorities, but it's the same as, these three are divisional priorities that I showed you on our strategic plan: primary prevention, finding the cancer early, and survivors. Next slide. Here, promoting access, looking at proven strategies, evidence-based interventions. You'll notice this is written a little bit more plain language, and studying policies, the PSE, studying policies and programs to make sure they work, evaluating the work we do. Next slide. So how do we utilize data? We talked about that earlier. Really, we have put all of our National Program of Cancer Registry data on the web. What you see here is an example of what you can get from that system. We are now putting in prevalence and survival. Those things should be ready in the next year. And so then you'd be able to do a prevalence in Wisconsin of the people, the cancer survivors in your state. You would know the survival. So this is something that we've been working really hard. I think we started about 3.5 years ago. And 4 years ago, when I first came, well, about a year after I started, to really make data available to people like yourselves, planners, without having an epidemiology and biostats degree. So you can just go here, and for working with, your advocates and other partners, we have the data, death data, and new case data by congressional district as well. So you're able to pull those data, and you could also look at state and county for planning. So really almost, if there's some other things you think you need, you could, query us, and happy to think about it. I'm sure they'll love to hear me say, have you guys thought about this? Next slide. Partners again, this is the national partners. As you see, everybody, a lot of people are on this group that help us to get it done. Most of the people on our national partnership are not funded by us. We fund a couple, the ACS and George Washington, to sort of coordinate the group, but otherwise these people are giving their time to us to help us because they're all passionate about cancer control the same as we are. Next slide. So how do we advance health equity in the environments that we're living in? So you guys have this, practitioner guide that we put up for advancing health equity. This is from, I believe, thanks to Alexandria for putting that up for us, the 211 link. But this is a guide from CDC looking at advancing health equity. What can we do around, like I said, policy systems, environmental change, partnerships? And I think you guys are the go-to group for that, because the Comp Cancer Coalition works all these areas with partners, connecting across the health department and any other partnership you need. And, we're making progress at CDC too. And one of my things is if we got to get out and talk to the people that can help us get the work done. Next slide. This is a group funded by our division with the Office of Smoking and Health, called Networking to Save. I don't know if any of you have worked with them, but they work on tobacco-related and cancer-related health disparities in the following groups: Asian Americans, geographic isolated populations, African Americans, Hispanics, substance abuse, LGBTQ, American Indian, and low SES. So we pretty much got every group there, and this is a network that you all are more than welcome, if you haven't already, more than welcome to hook up with to talk to, because they are national groups, and so they do have national representation in all of the groups that I described. And we really have this has really been a very nice collaboration between the tobacco people at CDC, as well as on the ground. Next slide. So this is one of the Health Equity Alliance actually looks at geographically isolated populations. And this is one of the things that they did for tips for smoking out in the country. I grew up in the country. So when I grew up out there, you would go by the barn and you'd see the Coke signs or the signs for the furniture store in town. So this is really what they're doing here, is using the barn as a billboard, for the tips campaign. And so it really is about finding the populations, going after the places they are, the things they see, trying to decrease the incidence of advanced stage in the populations that we serve. This group, we're starting to talk with them about how to get those, what those messages are, how to get them out. I think we're a little bit slow on the trigger here, but at least we're, working it right now. And so we're, we're going to get with them in the next 2 or 3 weeks to see what they need, and how what we do can complement what they're doing as well. And someone said, love the barn. I do too. I remember that from growing up as a kid in North Carolina. Next slide. Again, the priorities just, done another way, but it really is about primary prevention, early detection, and cancer survivors. So that word survivorship, sort of trying to train that word back to cancer survivors. When we have looked at all of our information, cancer survivors don't know what survivorship is. So when we changed our website, changed the words, all the things, we did a complete website redo. We changed all of our materials to cancer survivors, and the traffic to our website has just skyrocketed. So it's sort of, how do you speak to and this again is what I was talking about earlier, how do you speak to the audience that you're serving? How do you reach them? How do you get your messages to resonate with them so that you can actually deliver the messages that you need to deliver? Next slide. So the health equity approach is really, getting everybody, to get the apple off the tree, not equality, but equity. I didn't know this one moved. I don't like that. I can't keep up. But anyway, like what I just said, tailoring strategies to populations experiencing the greatest disparities. So the dual approach is helping everyone, the general population you see there on the left, but then what are we going to do to target specifically to those with the greatest need? And so, for example, over there, free or low cost mammography programs, such as the BNC program at CDC, and in Wisconsin is one of those ways that we can reach those populations while we're giving the general message, screening is important. Here's what you need to do. Here's why it's important, what you need to do. Next slide. I'm almost done, y'all. So the 4 keys, and actually, so one of the things I'm known for, as Melinda said, is when people ask me questions or want to do something or want to change my mind, my first question is, where's the data? Why are we going to do that? Why do we need to do that? Why do we need to change what we're doing? And I'm not being malicious or anything. It's just that, we have to use data to make decisions because our resources are very stretched and thin. So we don't want to waste money doing something that isn't going to get us to where we need to be. Next. And one thing to do, again, is expanding partnerships. I don't know if you guys have room to do that, but we definitely do at home, and at home at CDC. And what you see on the left there is, what are those different partners that we could get with to help us get our job done, like housing, transportation. As I said, the health insurers, we're trying to make an effort there, because the people who pay for the services have a lot of influence on what gets paid for. Sounds kind of redundant, but they do. They all have plans and, different, this is what we're going to pay for, this is what we're not going to pay for. And so they're very influential in that way. Oh yeah, you can have some. The slides. I keep reading the messages, sorry. Next slide. I think this is the last one. So, how do we, this is one of my big pushes too, has been communication. Like I said, the website is tremendously better than when I started. We just went through and we gutted the whole thing and basically killed it. We evaluated everything when we were killing it, by the way. We didn't just take it down and put it up. Lots of data telling us about what things worked, what things didn't work, how we need to change it, how we needed to organize it. And so we did that, and we've had a lot of success, a lot more visits to the website, people staying longer on the website, getting the information that they need to, to move forward and do what they do. But this is sort of and the latest thing we're doing are the simulated humans on the right there. It's a thing we're doing. The opening tagline is like, cancer doesn't wait. Well, here, talk to someone. And so we have a whole set of avatars, simulated humans, because you can interact with them for triple negative breast cancer treatment, prostate cancer screening and treatment, healthy behaviors in cancer survivors, mental health issues in cancer survivors. So we have a whole suite. So if you search talk to someone, cdc.gov cancer, it should pop up to that page where you can see all the resources that we have. And our social media stuff is pretty good, and many of you get our newsletter. So every possible way I can figure out, or we can figure out, to get information out, we've been doing it. And so that's my last slide, and there's should be time for questions. So thanks very much for your attention, and I'll turn my camera back on. I like to hide on these things, but I won't hide today. Thanks everyone for your attention.
Wow, Lisa, thank you so much. I mean, what an incredible talk. I really appreciated how informative you were in terms of the multiple contexts that affect cancer, like really thinking about how COVID is impacting cancer, health equity. And it was so, I don't know if many people saw the recent article looking at, as you showed in your data, what COVID has done in terms of cancer screenings and sort of this backlash of later stage diagnoses that we should be expecting, which is so unfortunate given all the health burdens impacting our communities. So I just wanted to say that I think your talk impacted sort of the value of us all coming together. It's like, why have a conference on cancer in the middle of a pandemic? But you certainly provided the data to support the value of this conference. And also, I think, sets it up well for the rest of the afternoon in terms of our state plan and how that really fits in with your vision and the strategy that you've put forth for the CDC. So I don't want to take any time away from questions because I'm sure there are many. I'm actually going to turn it over to Beth Brunner, who's going to moderate the discussion and questions for us.
Great. Thank you, Dr. Stolley, and thank you, Dr. Richardson.
Thank you.
Fantastic presentation. So we wanted to open it up to questions from the audience. And of course, it's a little different this year since we're all a virtual audience. So to see hands will be difficult. So feel free to put something in the chat box. Or if there's something I believe you have the ability to come off mute if there is a question that you had that you wanted to ask. So I'll give it just a few seconds here and see if we can see what questions might be out there.
So Elise asked if she could have the slides, and yeah, they'll provide the slides actually whenever they have a moment to do that. And I don't see anything else. Yeah. I mean, I will speak to the comment that Melinda made earlier about, not screening not happening and what are going to be the consequences of that. So, I mean, the perfect example of that is prostate cancer screening right now, right? When the D recommendation came out, people stopped screening, and late stage prostate cancer, is going up. So I think we can expect to see that. Not sure at what level, because it's, hopefully it'll be a short term, but it may end up being 2 years, who knows? So.
Yeah, it's a huge concern, I think. And I guess to follow that up, I know that there's a couple questions here, but in terms of addressing that, I mean, I know you talked about sort of doing these new campaigns, but have you within your team thought about how to talk directly about the safety issues and the real safety issues, right, of coming in for what some may perceive as unnecessary right now screenings, and how we talk with people about that?
So I think, the first thing is to, I finally, is to overcome the fear. People are terrified of going out and getting COVID, right? And so to talk about the fear, so I did a blog in June on This is Cancer, our blog that we do, where I had gone out because I was needing things. Maybe I just don't think about things the way other people do, but I needed my mammogram. So I went to see, it was time. So I went to see my doctor. We ordered the mammogram. Her office was, doing everything the right way. The mammogram facility, I called to see what was going on, and they were doing things that, the right way. Half as many women were there as usual, because they stretched out the intervals between the mammography appointments. So just to really help people understand that most places you go have put processes into place to sterilize things when you're there, after you're there, and also to ask. I went to the eye doctor, and there wasn't a sink in the room, and I asked them. I just asked them, "Have you washed your hands? If not, you can't touch my face." But to empower people to do that, because the average person is not going to ask the ophthalmologist to wash their hands, right? But if it's your health, you have the right to ask someone to wash their hands, because you got to go see the doctor, right? I think that, like I said, that, and it's just really, how do you transmit the message of, and the only way I can think to do it is like what I did, is to call the place that you're going and ask them what procedures do they have in place,
That
right?
is such great advice. I appreciate that because I think people are so hesitant
Yeah.
to ask questions like that. I know I went to the dentist and they didn't ask me the checklist, and they
Right.
said, we don't want to inconvenience our patients.
Oh,
And I'm like,
no.
I don't care about inconveniencing patients, because if I get COVID, I'm going to be really inconvenienced.
Inconvenience. Yep.
I love that proactive approach. Thank you for that response.
And that actually is I think it's in the blog, and it's probably going to be part of the messaging that we give, is that, you have a right to go somewhere and be safe, and you have a right to ask. But this has always been one of my things as an oncologist, a cancer doctor. When people come into when people come into your room, you should ask them to wash their hands when they come in, and I've always done that for 25 years. So it's just one of those things that this is your life. You have to take care of yourself, right? And make sure others are helping you.
So Dr. Richardson, we do
Yeah,
have some questions. So we
I see.
kind of great question. So I'm just going to start from the top and say the one question around suggestions on how to get representatives from insurance to be involved in the cancer control work and in the work of the Wisconsin Cancer Collaborative.
So that's a great question, because we've been like wondering that as well. Like, how do we do that? So the within the BNC program, I say would have the most experience with that, because when you have women who are uninsured, a little bit easier now with Medicaid, but there's still challenges. How do you get the hospital or the doctor to take the patient? So you still have take the patient's case, but really it's about reaching out. So let me see, we're going to try to help you at CDC. Let's start there. So we've been working with Levitt Partners, who actually is one of the health intelligence groups out there at the state level, trying to build models of how to interact or how to approach a health system, how to approach a hospital, how to approach an insurer. And we hope to have something, by mid next year, that we can share with people to sort of say, this is the, what's the word? This is like a checklist of things. But again, it's the main thing though, it's all about relationships. If you're working with people in your county hospital, your community hospitals, your physicians in your local area, that's usually the best place to start. But we are trying to, that's been one of those conundrums as to why we haven't been able to crack that nut. But we are working on it at CDC, and hope to have something to share with you next year.
Fantastic. Thank you.
Mm-hmm.
That sounds something to look forward to.
Yep.
Well, people are intrigued by your simulated humans. So
Oh,
there are a couple of questions. Just one
okay.
about, do they speak to certain cancers, the main cancers, breast, colorectal, prostate, or to all cancers? And then just a
Okay.
little bit more about them. How can we connect this kind of simulated human program to talking to real humans? And knowing there are peer-to-peer programs out there that
Right.
people can tap into.
So the thing that someone said, nice to patient empowerment. So one of the main reasons we built, so let me start from the beginning. I wanted something other than a pamphlet to talk to people. right? I was wanting something more than paper because people, they get it and I do that. I turn it just in the round file before I get to my car, right? So is there another way for us to engage people? And if you go to, like I said, if you Google talk to someone, CDC, cancer control, it should pop up, or DCPC, it should pop up at the top of the list when you search on Google. But it really is a way to empower people to run through a simulation, see what it's like, see what the treatment is like, see what the thing is like, let's say being more physically active, getting advice. And the main thing is you can go back to that thing 1,000 times and ask the same question, right? One of the things we get, number one, I forget to ask the question when I'm with the doctor. But a lot of people are just afraid to ask questions when they get to the doctor's office, or they forget. And so these are all free on our website because they were built with your tax dollars. So like I said, but they had to be free. That's why we didn't go with a contractor. We went through a cooperative agreement with the National Association of Chronic Disease Directors. And so everything we've created is free to you all. So we send it out in a newsletter, but I'm happy to resend the page when, or just go to the page on the website and share with everybody. But they're really cool, and you start talking to them too. The breast cancer survivor, her name is Linda. The prostate cancer simulation, his name is Nathan Bennett. And once you start interacting with them, they just have one challenge: you have to be able to read. It's very simple. And so my next goal is to have a rollover or something that can read to people, those who are can't read or have low literacy. So that's the next goal, and everything's in Spanish.
Thank you.
Yeah.
So, Dr. Richardson, there is a couple of questions here that's dealing with how do we improve the numbers of people not getting medical attention, and specifically talking about how do we prioritize catch up for high risk patients when this pandemic is over. So, how are we really making sure, one, that people are getting the medical attention they need, and two, how are we making sure those highest risk patients are prioritized in getting in for those checkups?
That was a really good question. So the doctors who are thinking that their patients are getting worse, and it probably is true. The telehealth has been one way to do it. I mean, if you don't need a physical exam, telehealth is one way to do that. Like to do because I do my own blood pressures, you do your own glucose at home, and sort of report that back to the doctor or nurse or other healthcare provider that you're talking with. Um, but other than that, it's just if you have to go. I mean, my sister has a ton of health problems and she never misses a doctor's appointment. So I'll have to query her, like, what is that about? She says, I don't have to wait, Lisa. His room is empty. So for her, it's like an incentive to go because she doesn't have to wait an hour and a half. So I don't know. It's just one of those, again, assuring people that your doctor's office has procedures in place. Everybody has to wear a mask. I mean, they throw us out in the places I've been to. My doctors throw you out if you won't wear a mask, just those things to protect yourself. But if you really need care, to be perfectly honest, somebody told me, they're like, the doctor's office might be the safest place to be because it's been wiped down every hour 1,000 times, right?
Right.
Might be the safest place. Mm-hmm.
So I think we have time for one more
One more?
question,
Okay.
and if you don't mind, and then maybe we can catch some of these follow-up questions after, and maybe get some of your thoughts on it to share with
Oh
the
yeah, send them to
participants.
me. I'll be happy to
Okay,
answer
great.
them, send them back to you. Mm-hmm.
So the last one really has to do with COVID, and how we're kind of where we're at as a state, and the change in treatments that might occur, the messaging that we're trying to do. But do you have any recommendations you could give us as a coalition on how to navigate the long-term impacts of COVID on our state?
Um, so for us at CDC, we got the same challenges. The first challenge is the data, right? What are the data to show you where the places are that you need help? Like I said, I think the 211 kind of grid thing can help with that a lot. If you go down to the bottom if you look at the healthcare one, you can see who's asking for COVID, but keep COVID information, but keeping track of what the resources are in your area. You can't control the hospitals. I don't know what it's like there, but here in Atlanta, the hospitals are filling up because there's so many people with COVID-19 right now. I saw a story from Wisconsin, the same story. Just try to keep up with the information that's going on in your area so that you can direct people to resources. And 211, if anybody asked me, I would just say, call 211. They got all the resources right there in one place. One thing we're doing in DCPC is right now we're in the middle of building, I think we talked to some people about this on the Cancer Council, but building a resource hub for information for cancer control and those types of things, like where to find food is cancer control, right? If you don't have anything to eat, you can't get your chemotherapy. And so it's just all of us trying to see the holistic side of taking care of people. I'm sure that did not answer the question, but
it was a big question, and maybe we'll just all work on it together moving forward.
please do. And
sounds
if I
like.
think of anything else, I'll send something back when I get the questions.
Great.
But it really is to be aware of what's available in your area and who's there and what you can get to. And 211, like I said, I talk about it all the time. It's a great resource. And now that they've hooked in the cancer control kind of things after that project we did 20 years ago or so, can't believe it's been that long, but there's been a continuing connection between referring people for medical stuff, not just, food, water, housing, all that stuff, but more to some of the sort of extras, you would say.
Well, thank you so much, Dr. Richardson. We're so glad you could join us today. I'm
Okay.
going to turn it over to Dr. Stolley.
I hope everybody's back, comfortable. So I am so excited to introduce our next speaker. Sarah Kerch is the program director for the Wisconsin Cancer Collaborative, and she is the brains behind the plan. She worked tirelessly, of course, with the incredible staff around her, to develop the 2020-2030 Wisconsin Cancer Plan. For those of you who don't know Sarah, she is, like Lisa, a tireless champion of reducing the cancer burden in Wisconsin, and embraced taking this plan on and making it not only comprehensive and thorough, but usable, which I think is probably the most important characteristic it has. So she is going to share sort of the national approach to cancer control that was discussed by Dr. Richardson, but we're going to see it in action through Sarah and how it was applied here in Wisconsin. And then sort of give us all hints about how we are all going to take this plan and work together to reduce the cancer burden across our great state. So Sarah, take it away. Thank you.
Thank you so much, Dr. Stolley. It is really a joy to be with all of you today. It really is a team effort. Speaking of Dr. Stolley, she spoke so highly of me in advance of this that I had to show my cards, and that really I can't do it without the team. Really is a team effort. We've experienced just a tremendous amount of changes over the last few years, and it is just such an honor to have such a dynamic team right now. But as I mentioned laughingly, Dr. Richardson and I happened to wear the same wonderful yellow dress several years ago, and so she and I are connected by wardrobe now. Not only does she have a love for data, but shares my love for Target dresses. Again, I am so grateful to have all of you here, and we'll get resettled. So I'm just going to talk briefly today to share a few highlights of our new state cancer plan and provide a brief overview so that you all can review the plan independently and hopefully save time today to hear from your peers. I'll hopefully give you a little inspiration to make sure you get the most out of this year's summit, even if it has to be virtual, and ultimately leave after the next few days with one way you can take action. So for those that might be somewhat new, the Wisconsin Cancer Collaborative is a statewide coalition of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. And Tina, actually, if you could go back 2 slides backwards, we'll get our acts together, I promise. There we go. Staff work to connect members to each other and provide them with the tools, support, and knowledge they need to create healthier communities. Okay, next slide, Tina. Thank you. So first, just a little summary of comprehensive cancer controls and approach. We're funded by the CDC, as Dr. Richardson mentioned. Grantees include states, tribes, and territories. Every state has a comprehensive cancer control program and coalition. Grantees are charged ultimately with convening partners, most often in the form of a coalition, to determine the impact or burden of cancer in their specific geographic area, establish a blueprint or a plan to reduce that identified burden, and ultimately take action on the blueprint. So today and tomorrow, we, as the Wisconsin Cancer Collaborative, our state's cancer coalition, will review our very own blueprint, the Wisconsin Cancer Plan 2020-2030, and hear from fellow members and partners on how they have and will continue to implement this blueprint. Next slide. Work on the Wisconsin Cancer Plan 2020-2030 began with the leadership of our 20-person steering committee, who you all met earlier virtually, in February of 2019, and continued through their guidance, along with the membership and expert input through July 2020. Chapter experts were consulted in the spring of 2019 for initial input, and again in the spring of 2020 for review. Members and partners throughout the state were then given the opportunity to share input via an initial survey, a webinar, and in-person meetings in June 2019, and once again focused on equity in October 2019. I realize this slide with the membership is nearly impossible to read, but it's because we have so many contributing organizations to the Wisconsin Cancer Plan. So not only do I have a team saving me in dire situations, but we have 140 organizations all listed here that contributed so wonderfully to the cancer plan, and we really could not have done it without them. We're immensely grateful for their time and expertise. So I'd also like, again, to take a moment to thank the team I work with alongside every day, whether it be virtual or in person. They put such a tremendous amount of time into distilling the feedback from members and reviewing the evidence to come up with this final project. It was really a team effort. Next slide. And while the plan was officially made available in August of 2020, today serves as the official launch of the Wisconsin Cancer Plan 2020-2030. An important change to recognize with the Wisconsin Cancer Plan 2020-2030 is its 10-year span. In previous iterations, the cancer plan would span 5 years. Realizing the tremendous effort needed to create a strategic plan while also needing to take action, the steering committee determined a 10-year plan with the opportunity for regular revisions was the best approach moving forward. That said, change requests, though, are available to all of you to make due to evolving evidence, recommendations, and best practices. They can be submitted at any point and submitted online. There is a space online, actually, that you can go ahead in the interactive cancer plan with a link there. Revision requests will be reviewed by the steering committee on a quarterly basis to determine what revisions need to be incorporated. And we'll stay on this slide for the person who's advancing. I think that we've switched some roles here. So there are two versions of the cancer plan. One is the PDF or print version. Depending on when you registered for the summit, you should have received one in the mail. And if not, you'll be receiving one soon. There's also an online interactive version, which I referred to earlier, which includes all of the information found in the print plan, as well as a few additional features, including granular activities, or what we refer to as action steps to implement the plan, a new resource center to help take action in specific areas, and measures, which will be updated regularly to track progress. So we made those online to make sure that the data is readily accessible, and then also to make sure that the data is updated on a routine basis. So next slide. The vision of our cancer plan is a healthier Wisconsin by reducing the burden of cancer for everyone, which is very similar to previous versions with the addition of for everyone to highlight a greater emphasis on equity. The mission shows how we'll accomplish. It looks like we're having some technical issues again. So, and then the mission shows exactly how we'll accomplish this vision to engage diverse partners to develop, promote, and implement a statewide comprehensive approach to cancer control. Next slide. There are 6 overarching goals, which were all established by the steering committee and used as a frame to build out the remainder of the plan. Goal 1 is advanced health equity as it relates to cancer. It's a new addition, whereas the others are slightly revised from previous iterations. The 5 remaining goals include reduce the risk of developing cancer, detect cancer at the earliest stage possible, reduce the death and suffering from cancer, improve the quality of life for cancer survivors, improve the quality of use of cancer-related data. Next slide. And in addition to the goals, the cancer plan uses a policy, systems, and environmental change approach to address the burden. We know that healthy behaviors do not happen on their own, and rather they're shaped by the policies that govern our communities, organizations, or systems, as well as the physical and social environments in which we spend most of our time. The new cancer plan promotes individual health behaviors that are strongly supported by policy, systems, and environmental changes to reduce the burden of cancer for everyone in Wisconsin. And ultimately, it's important we all have a role in shaping and creating policies. When these types of changes occur, they can create lasting health improvements for everyone. Examples include a teenager being less likely to smoke when a community enacts laws to limit youth tobacco access, or a parent more likely to vaccinate their child to prevent HPV infection when a medical provider recommends the vaccine, but that medical provider is also more likely to recommend the vaccine when a reminder system's in place. And finally, a cancer survivor will be much more likely to engage in ongoing physical activity to prevent future onset cancers if they have access to community spaces, such as open gyms and safe sidewalks. Next slide. I will try to speed up a little bit, knowing we're a little behind. So the 2020-2030 plan includes 7 chapters. Chapters 2 through 6 span the cancer care continuum from risk reduction through end of life, with 2 very important bookends: health equity, chapter 1, and chapter 7, data. Okay, can we advance to the next slide? So equity has been incorporated through the Wisconsin Cancer Plan as a cross-cutting issue in the past, but new to the 2020-2030 plan, it's an entire chapter dedicated to equity. Everyone in Wisconsin deserves a chance to live life to the fullest, and this means having the resources needed to make healthy choices and receiving the highest quality of care. Unfortunately, too many Wisconsinites are denied this opportunity because of historical and contemporary injustices, geographic location, and critical gaps in cultural responsive healthcare services. So just as we recognized in previous iterations of the cancer plan that equity was important throughout the cancer continuum, equity remains threaded throughout every chapter in addition to its standalone section. Next slide. So I know you all know the importance of this work. You obviously do, you're attending. But I'd like to take a brief moment with a little bit of my own personal reflection to think about why this work is so important. Dr. Richardson spoke on leading through change, and she realized and mentioned as well that it's harder than ever right now. And it's frankly easy to find ourselves asking, what's the point of this at all anyway? Will a document really make that much of a difference? Next slide. The point is everyone. Our new vision added the word everyone. And why is one word so important? Because everyone is important. Every person is someone's child, someone's neighbor, someone's something. Next slide. My everyone is my grandpa, Edgar Bauer, not the name behind the clothing brand, Eddie Bauer. He was one of the most important people in my life. He was drafted in the Korean War, but the war ended before he arrived. He got lucky to not fight in combat, but he was not so lucky later in life. He grew up on a dairy farm in Dodge County, just outside a 200-person town of Leroy. He married my grandma Betty, continued the family tradition of dairy farming, and had 8 children. One was my mom, Terry. He was the rock of the family. For years, we worried about his heart. After suffering a heart attack, he was in and out of various surgeries and scares. It caused him to stop smoking and begin drinking non-alcohol beer. Unfortunately, his 40 years of smoking had been 40 years too many. On September 28, 2007, just 3 days after my birthday, he was diagnosed with stage 4 lung cancer and given about 6 months to live. I had returned back to my hometown of Fond du Lac to have a small family birthday celebration. And when I arrived home, my grandpa and grandma were there waiting to tell me the news they had also received that same day. I remember telling my grandpa that he didn't need to be there, that he probably had too much on his mind to eat birthday cake. And I still remember his response to this day. I'd crawl to you if I had to. I'm not missing this. But he deteriorated quickly, and the cancer spread quickly to his liver, causing us to only have a few lucid days with him. He turned 75 October 13th and passed away the next morning, October 14th. We only had 16 days with him, not the 6 months we'd hoped, but then been devastated here just days earlier. It was that experience and his lasting memory that frankly gotten me inspired to work alongside every one of you today in public health and more specifically cancer control in Wisconsin. With every potential person I could impact in my work, I think of my grandpa, how everyone now is truly my everyone. How can I make sure commercial tobacco doesn't continue to devastate families like mine? How can I make sure lung cancer screening is available to patients like my grandpa? It wasn't available earlier, and boy, I really wish it was. To make sure those families have more time and have their loved ones longer than we did. And how can I make sure that everyone's aware hospice care, we were so grateful to receive, can make sure their loved ones are given the respect and care they need during their last days, their last breath. Next slide. So I recognize it's impossible to not feel tired right now, and I can only begin to express my gratitude for public health and healthcare workforce during this incredibly challenging time. Through the hard days, the days you ask yourself, what's the point? Do you have that one person you can remember to inspire you to keep pushing forward? I want you to take today and tomorrow to think about that person. Think about how despite the adversity we face now, we can get through this together because frankly, everyone needs us more now than ever. At the risk of sounding cliche, we really can be the change we want to see in this world. And cancer doesn't stop for a pandemic, and neither do we. So spend today and tomorrow, listen to others as they share about their work, introduce yourself to someone new. It's really hard to do virtually, but we believe in you all. And just pick one thing that you can easily do after the summit. The plan has many evidence-based, promising practices to take action. But first and foremost, remember that you're everyone too. Taking care of yourself is so important right now and always. I want to close as well and just mention that we recognize that the cancer plan is incredibly comprehensive, and our intention is not to overwhelm you with another task. But I will mention that we have action areas being developed now to help you through that, to make sure that we're prioritizing our efforts in the areas of greatest need as well. And so with that, I am so excited to learn from our experts across the state on how we are putting our cancer control priorities into action. So we can go ahead and advance to the next slide. The approach, so we'll lead into now our panel, learning from our partners across Wisconsin. The approach I discussed is nothing without all of you, as I mentioned, our experts putting into action. We will now hear from a few partners regarding their successful efforts across the cancer continuum in Wisconsin on today's panel. Okay, we'll just take one quick pause. I now would like to introduce today's panel. We have Mehua Mawa, Executive Director for the Milwaukee Consortium for Lung Health. Mehua's passion in helping people inspire her to co-found several nonprofit organizations that support refugees from Southeast Asian countries, as well as serve on the board of directors for organizations at both the local and national levels. Currently, Mehua is the Executive Director for the Milwaukee Consortium for Lung Health, which she co-founded with 4 other members. Carol Cameron, Program Manager for the Wisconsin Pink Shawl Initiative, is an enrolled member of the Minnesota White Earth Chippewa Tribe and one of the founding members of the Wisconsin Intertribal Pink Shawl Initiative. Carol, a breast cancer thriver herself, works to educate American Indian women on the importance of regular screening and good breast health habits will reduce the incidence of breast cancer in the Native community. And Andrea Larson, Oncology Nurse Navigator for the Cancer Center of Western Wisconsin. Andrea has been a member of the Cancer Center team at Westfields Hospital since 2011. She has worked as the Oncology Nurse Navigator for 3 of those years. Andrea helps new patients begin their cancer treatment path and has worked on several projects, including community education and most recently, helping to develop a survivorship program for the Cancer Center. Megan Federig, Director of Market Development for Vitas Healthcare. Megan is the Director of Market Development and has worked at Vitas Healthcare for 11 years. Through professional outreach and community engagement, Megan helps people understand advanced illness and the importance of having timely conversations about healthcare planning, such as documenting goals, values, and wishes so that dignified care can be provided as disease progresses through the end of life. And finally, we have Dr. Noelle Conte. She's the Associate Professor of Medicine for the University of Wisconsin School of Medicine and Public Health, with clinical interests in GI cancers and cancers in older adults. She is the principal investigator for multiple federal grants, as well as clinical trials of new chemotherapies for GI cancers. Dr. LaConte serves on various committees at the American Society of Clinical Oncology and has become national leader in researching and raising public awareness about the connection between alcohol consumption and cancer risk. Dr. LaConte is not able to join us in person today, given the healthcare demands currently being faced in Wisconsin, but we do have a recording for you for all to share during the panel. So each panelist will share their success story, and then we'll be facilitating the Q&A at the end of all presentations. So if you have a question, please feel free to type it into the chat box at any time, and we'll make sure to answer those at the end of the Q&A portion. So with that, I would like to introduce Mehua Mala. Thank you.
Thank you, Sarah. Thank you all. As introduced, my name is Mehua Mala, and I am Hmong. I came to the United States as a young refugee child 45 years ago. And so with my people, the Hmong community, lived through a lot of health disparities, and especially not understanding how to utilize the Western medicine system. We faced a lot of health issues that could have been prevented. And so in 2007, we were informed of a research that discovered that we have a very high mortality rate of cervical and breast cancer among Hmong women throughout the state of Wisconsin. And we're approached to see if we want to do anything about it. And so that's how we began forming the Milwaukee Consortium for Hmong Health. And so through our work, we wanted to make sure that we are going to be able to reach out to the community, to engage them in our education, to help them understand what cancer is and how they can help themselves and prevent death among the Hmong women especially. And so with that, we formed and developed a mission. So our mission, if you could go to that, okay. So our mission is to engage, we started out with to engage the Hmong American community for positive change regarding to chronic diseases and cancer, health, and wellness. But then as we continued to work and we saw a growing community of Southeast Asians around us, we decided to expand to include other Southeast Asian into our work. And so now our mission is to engage the Southeast Asian American community for positive change regarding to chronic disease and cancer, health and wellness. So again, I gave you the introduction of why we started, because of the high mortality rate of cancer death, specifically with breast and cervical cancer among women. And so we wanted to help reduce the health disparities that the Hmong was facing, and now the Southeast Asian community. So how we do this was that we discovered that we needed to train community health workers that can go out into the community, do one-on-one education, do small group education about breast and cervical cancer. That was our full focus at that point. And as we continue to do the education and engage our communities to allow us to help them, we discovered that many of them may have health insurance but don't know how to utilize it, except for those that had Title 19. Then they know that they can go to the doctor and access health care. But then those that have private insurance through work, they don't know how much the insurance will cover. They expected to cover 100%. Now they're having to pay a certain percentage. And then there's co-pays that they have to do to deal with. And so we had to learn how insurance worked and help them, assist them with that. also many of our population that we work with don't speak English or have limited English proficiency. And so we also need to help make appointments for them to see the doctor. Sometimes we attend the doctor's appointments with our clients. Sometimes we have to transport them there, although it's not recommended. But you know, when you're working with new immigrants to this country who don't know their way around yet, don't drive and don't have vehicles, you can't help but take the risk of transporting patients to their doctor's appointments. Also to make sure that they are getting their health screenings. And so through our work, yeah, and with the wonderful many partners that we have, we continue to develop resources that will help us access for our clients. And then we also bring our clients in for monthly workshops where we also invite medical students that can come in to do vital checks on our clients, such as, you know, blood pressure check, weight and height, and then recently blood sugar checks. And we felt that that's not enough. So then we would have to, you know, bring a larger group, a larger crowd together so that they can see how many people we can, you know, impact. And not only that, also bring in professionals. So these are the kinds of things that we are doing at the Milwaukee Consortium for Hmong Health. Next slide, please. Okay, so these are just some pictures of some monthly workshops. We started out with breast and cervical cancer education. And as we continue to reach out to the community, many of our men were questioning us why we only focus on women's health. Why can't we include the men's health as well? And not having the capacity to reach out to the men as we would like to, and all of our community health workers are women. So we decided that we will focus on what is most relevant to our community. And so I'm sure many medical doctors that are on this conference, you know, is aware. Liver cancer is a very high chronic disease among the Southeast Asians due to the fact that we come from a very low socioeconomic background where hygiene is an issue, and plus other exposures that we have during our war-torn country years that we encountered. You know, hepatitis is also very common among the Southeast Asians as well. And so we decided that, you know, we need to incorporate something for the men, even though we try to educate them that, you know, some men do have breast cancer. We also need to put something out there that would be more relevant to them. And so liver cancer is a cancer that we chose to make sure that we are including the men in our education. Not only that, you know, our men are also exposed to smoking and alcohol. And in the Hmong culture, when we have events, family events, alcohol is a big thing at the table, not just for fun, but it's part of the rituals that that happens at our family events. And so then, you know, even though during the week our people don't drink, but weekends is when we get together and do celebrations of maybe a welcoming of a new bride into the home, or a new baby into the home, or a guest from out of town. Alcohol is a main liquid that we have to, beverage that we have to serve. And so it's more like, from my perspective, it's more like binge drinking during the weekends. And so we have a lot with hepatitis in our system already, you know, to add alcohol and binge drinking that way. You know, liver cancer is a big thing, especially among the Hmong community. And so we chose that. We also have very high diabetes and hypertension among Southeast Asians. And so, you know, we have to incorporate that into our workshop as well as clinical breast exams, hepatitis educations and screenings. And then, of course, in spite of all, including all of this, we also have to focus on our nutrition education. Nutrition is very important to us. We have, coming to America, we have adapted to the fast food restaurants for our children, that we don't push our ethnic food onto the table for our children anymore. And so we felt that nutrition is very important for us to educate our community about and encourage exercising. Next slide, please. So the database that we're showing here is just based on what we have recently, just in 2019 to 2020. For 2 full-time employee of the organization, we do our outreach, and so we were able to reach out to 295 individuals, and 252 are females. And then, of course, again, we try to incorporate in our male population into our education. Not only that we need to educate them about cancer, but we also need to educate them so that they are aware of what the women in their lives could go through that can affect them. And so with this, we encourage men to participate at every one of our workshops. Of course, not everybody comes. And because of our Well Woman program, we focus with 35 to 65 years of age range. We also do have other clients that we serve as well. And we don't have that included on this data that we're sharing with you. But navigation for resources and services is very high. We don't serve just the women and the clientele that we have in our system. We sometimes have to help make appointments for the children, for an eye exam, or for a dental appointment, what have you. We also assist them with registering for to vote. We assist them with changing their IDs, especially when they move, and then getting screenings done as well. And so these are just some further informations of what the kind of data that we collect, what kind of insurance they have. If they don't have, where can we find resources that can provide that we can help them with, or get them to a free clinic. So all the things that we do here at the consortium. Next slide. And then to document everything that we do in their case file. So we develop case management for all of our clients, whether it's just for education. Sometimes after we educate them, they decide they don't want screening or they don't want our services anymore. That was fine, but we still keep their case files open until we can no longer reach out to them. But case management helps us document everything that they go through, so that in case they have any questions, or they don't remember what they have, what the doctor diagnosed them with or prescribed them with, we have that information ready for them to utilize. And then also it helps us to help move them on to the next phase of other health services that they need. All of these, we feel that that is very important for us to do for our community, because we need to make sure that we are contributing to this society. And in order to do that, we need to be a thriving, healthy Southeast Asian American community. Next slide. So as I said earlier at the beginning, we combine our, we do one-on-one small workshops. Once a year, we bring everybody together, and that everybody means bringing the community, bringing professionals, and bringing survivors together to share and learn from each other. And so on this picture, you see we bring in, we work with our college and university students locally. We work with our Hmong medical professionals. We bring them in to be our keynote speakers, so that our people can hear in their native language, the importance of why screening is a must. And then of course, if you can see on the bottom left side, we have a young woman, who had breast cancer. Who would have known that a 24-year-old Hmong woman, a young Hmong woman, would have breast cancer at such a young age? So these are things that we're trying to bring as a reality to our community so that they understand better why we are doing what we're doing, why health screening is important to our community. And then of course we include our medical students, especially those from Medical College of Wisconsin. They work with us every year, doing hepatitis screening as well as blood pressure checks. They volunteer with us every time we have something. So very, very fortunate to have wonderful networks and partners in our work. Thank you.
Thank you,
Now we
Melinda.
welcome Carol Cameron. Oh,
Hello, this is Carol Cameron from the Wisconsin Pink Shawls. And thank you, Sarah, and everyone else for joining us today. This is a wonderful new experience from previous years. So I look forward to presenting what we do at the Wisconsin Pink Shawls and what we've been doing over the past many years since we started. So what I'm presenting on is our program, the Dream the Cure Conversation program. Next slide. The Wisconsin Pink Shawl Initiative, we were established in 2007, and this was done by a group of women who actually were board members from the Indian Summer Festivals and community women in the greater Milwaukee area. Excuse me. And we realized that there were 4 of us on the board of directors for this festival, this annual American Indian Festival, that all were survivors. We had recently had one of the board members who was just diagnosed. And then later, I too was diagnosed with breast cancer. So we felt this was a message that was kind of being overlooked by the cancer agencies that we normally would see advertising and addressing the various communities, the communities of color. So we felt we wanted to bring the awareness to the community, and we had a platform and we had a venue to do it at, this festival, which took place, I should say, in September on an annual basis for 32 years down at the Summerfest grounds. Our focus was really to educate American Indian women on the importance of breast health and screenings. And we hoped to improve the general outcome of health by doing this. And we continue to educate women throughout the state by our Dream the Cure Conversation program. Next slide, please. When we first got started back in 2007, we did have some community agencies that reached out and helped us man our first outreach table at the festival. But our main effort was really bringing awareness to the community through the wearing of pink shawls. This group of women, we got together, we made shawls, and we wanted to have an impact at our powwow at the Indian Summer Festivals. So it was very impactful. We had well over 40 some women all entering the powwow arena with pink shawls on and bringing a sense of awareness that we hadn't seen in the past. We are a volunteer organization and it's made up by some supporters and also survivors as well. Next slide. Some of the events that we do to keep ourselves out there in the community, we have our outreach table, which provides information in regards to screenings, the types of screenings, not only breast cancer, but all types of cancer screenings, resources as well. And we do this at various events, either at churches, clinics, conferences, craft fairs, health events, powwows, screening events. We do our own screening events, and schools and universities. Next. In 2011, Susan G. Komen started a program in the greater Milwaukee area, and it was called the Conversations for the Cure, and it was funded by the Kohl's Care. And this was done in southeastern Wisconsin. And there were 6 of the pink shawl women who did go for the training, and we started to educate women in the greater Milwaukee area and Racine, Kenosha area in regards to this particular program. This was an incentive-based program where you went and educated them, and then upon enrolling in the program and going through and getting screened, they were awarded an incentive that was Kohl's gift. And this was a very popular program, not only in our American Indian community, but throughout the southeastern Wisconsin, those programs that those communities around the greater Milwaukee area. Next. In these educational programs, we would help women also connect with resources and support depending on what their needs might be. If they were survivors, we connected them with after breast cancer diagnosis. The Wisconsin Well Woman program has been extremely helpful in regards to getting our message out there and getting women connected to health services. The American Cancer Society was a wonderful resource as well, along with the Wisconsin Women's Health Foundation that have proved to be a wonderful supporter of the organization. Next. One of the events that we do, and we would do this twice a year, would be our annual screening events. And through the help of Ascension St. Mary's, they would bring in their mobile mammogram unit, and the nurses affecting change would come in and do clinical breast exams. Gerald L. Ignace Indian Hill Center would send in someone to do the basic blood pressure and glucose screenings for us. So women could come into a community setting, feeling comfortable, getting the educational program, the conversation program that we offered, and they would then be able to have their mammograms and these basic screenings, have some conversation, ask questions that maybe they didn't feel as comfortable to ask when sitting in front of their own health provider, but we were able to address some of these needs and made them feel more comfortable, and suggested other screenings if they posed any kind of issues that they might have had. And they felt, like I said, they felt more comfortable being in a community setting opposed to going into a large hospital setting or screening setting. Next. So in 2012, we had the idea that, we had a great success record with the Komen program, and we had approached Komen in regards to being able to take the program that they educated us on and take it to our tribal communities. Now, Kohl's did not support that program in the tribal communities, of which we have 11. So we sought resources to fund our own program. It wasn't at the same rate as Kohl's was doing because we couldn't secure that kind of funding, but they granted us the use of the program, and we rebranded it as our Dream the Cure Conversation program. Had all the earmarks of the Komen program. We taught the same information. We supplied the same sort of forms, and we also included an incentive, which was a $15 Walmart card, because that is what the women in the tribal communities had said that that would best suit their needs. They did not have Kohl's stores up in the northern part of the state as readily available to them as a Walmart store, as we all know. So we chose to go with a $15 Walmart card. So we educated the women, we gave them the materials that they needed, we enrolled them in the program, and once they went in and had their mammogram or clinical breast exam, depending on the age-appropriate screening, they were then awarded the gift card once the redemption card that we provided them with was sent in. Our program currently is now funded by the Wisconsin Well Woman Program and is taking on a little different look during the age of COVID. So we're trying to navigate through what we can do and how we can reach those communities again. Next. So we have inspired some of the communities that we've gone to where they've taken on their own Pink Shawl initiative and working within their own communities to encourage other women to get out and get screened, to bring in awareness. And this lovely shawl that you see in the top is from our Red Cliff partners who are actually doing our program for us remotely. And it has been successful. They have had the Marshfield Clinic that comes in and brings their screening units to that community. That was probably the biggest issue in regards to our tribal communities, is the lack of screening facilities or the distance that women would have to travel to go and get screened. So we are greatly appreciative of those organizations like Marshfield, like Ascension here in Milwaukee, that have mobile units that can travel to these communities and provide those screenings. Next. Our Conversations program. So a little bit about our Conversations program. We do a welcome package. They get a wellness bundle, which consists of the screening information, the registration forms, the questionnaires to measure the amount of knowledge they have in regards to screenings and what are available and when they should have them. Presentations are made with a discussion and question period so that women can feel comfortable amongst themselves in asking some of these questions. Like I said, some of these women, you know, they may be intimidated when they're in front of a medical, or maybe they forget, or they just don't want to ask. So we get some interesting questions, and it's actually kind of a fun time to get together with some of these women. It's kind of a hoot. They're very funny when we get some of these discussions going. So we promote self-awareness and educate women on the typical norms of the body and any kind of changes that they should be looking for. And we encourage them to, if they notice changes in their body, that they take that to their medical provider or seek medical attention. We're not medical providers ourselves or have that expertise, but we do allow women to contact us and ask for information or resources or what they would want, where they should go. Next. Some of the communities that we have gone to are Bad River, Oneida, a number of times, Menominee. We hold our events at the Southeastern Oneida Tribal Service Office here in Milwaukee. Potawatomi has a couple of locations. Red Cliff. We have participated since really the beginning of the Share the Care Cancer Conference, which is a American Indian Cancer Conference that is held statewide and travels the state. In 2019, we hosted the conference here in Milwaukee. This past year, it was supposed to be held in Green Bay at Oneida, but unfortunately, COVID affected that. And we've been to Ho Chunk. The women that we have who participate in our program, the majority of them, we have a little bit over 56% of the women that participate in our program do go ahead and get screened. And I think the incentive is a benefit to those women, and that's really what gets them through the doors and to get those screenings. Some of the obstacles that we find with our program and reaching these women are sometimes we have a transient community that may travel between reservation to maybe a large metropolitan area like Milwaukee. They may have family here. So catching up with women to remind them of getting the screenings, maybe challenging email addresses may no longer work. So, but we try our best in regards to maintaining a contact with the women and seeing that they try to get screened. Next. We find 1 out of 3 women were aware that breast cancer increases as you age through our questionnaire. Many of the women indicated that their screenings were often overlooked, and which we found was interesting in these tribal communities. More often do doctors focus on maybe diabetes, blood pressure, heart disease, smoking, rather than mammograms, especially if women were, but we had women that were in their late 60s that said that they were told they no longer needed to have mammograms in these checkups. So we found that very interesting, and we really encouraged them to push forward. If they were good, healthy women, we really wanted them to get screened, unless there were some other issues that might have overseen these women's health impact. Next. Women who participated in our program really were more apt to get their screenings done if they were done right in their communities. Potawatomi, Red Cliff, like I said, had Marshfield coming to their community. Oneida has screenings done in their community as well. So if they didn't have to travel, those women really were able to participate locally, didn't have to take them out of their community settings, and those were the ones that were most likely to get screened. However, we did hear of many women who had to travel quite a distance to get screened as well. But and there are many misconceptions in regards to screenings. Some are cultural and some are just myths. So when we have our conversations, that's what we talk about as well, and try to educate women on, you know, the importance, and some of these things may be old wives' tales that they've been subject to. Women like I said, women like dealing in small groups. We have refreshments, and it's more of a coffee clutch basically, and an outing for women. So they really enjoyed that. And without the community partners that we formed over the years, we really could not have sustained the work from 2007 up until today. Everybody has been very helpful, from the Wisconsin Well Woman Program to after breast cancer diagnosis, the American Cancer Society, Ascension St. Mary's, Susan G. Komen, UWM School of Nursing, and the Southeastern Oneida Tribal Service Office, the Wisconsin Women's Health Foundation, and here in Milwaukee, the Gerald L. Ignace Indian Health Center as well. And we look forward to continue our program. We're setting up, doing some virtual presentations ourselves, reminding women that cancer doesn't stop for COVID, and we really need to maintain those screenings, no matter if it's breast cancer or if it's colon or whatever health issues that they may see or may be affected by it. We really need to get out and get screened. It is safe. So thank you again for allowing us to present, and I'd be happy to entertain any kind of questions. We can be reached at dreamthecure.org or on our Facebook page.
Great.
Thank you so much, Carol. Go ahead, Beth.
I was just going to welcome
Andrea?
Andrea.
I'm Andrea Larson, and I am the Oncology Nurse Navigator at the Cancer Centers of Western Wisconsin. Just a little background, we are a rural cancer center. We make up, there's 6 cancer centers that make up our whole consortium. I work at the Westfield Hospital One, and we started a project this year to kind of redevelop our survivorship program. So I'm just going to share some information about that and what we did to get this program going. Being a smaller hospital, we do have 2 oncologists and a nurse practitioner, and we currently, our nurse practitioner was, oh, you can move next slide, sorry. She was seeing patients, and we just needed to redevelop what was going on because it was kind of discombobulated. So we put a team together, Jackie Nelson, who's our director, Lisa, who is our manager, Courtney, who's our psychotherapist and social worker, and then myself as the oncology nurse navigator. Next slide. So basically, we used the model for improvement. The foundation was we wanted to plan something, do our plan, study how it's working, and then act on it, and keep that whole cycle going so we can learn from our mistakes and learn what we need to keep working to get it better and grow the program. Next slide. We use developmental tools to do this. We had what's called the A3 review, and that's just basically a sheet of paper, but it helps us to develop what our problem was currently at our site, get a scope, and then get some target aims for goals. We also did some observations. We observed our nurse practitioner and what she currently was doing with patients who had labeled survivor visits, and then mapped out those visits and looked at things that stood out as problems. Or things that were good. We also did some data review of that and studying that. And then we went to a couple other sites. We went to Marshfield Cancer Center and visited with their navigator for their survivorship program. We went to talk to a nurse at Alliance Systems in the cities, and also with Park Nicollet Health Partners in the Minneapolis-St. Paul area, just to get information on their programs that they currently have. We also did data review and literature review from COPE, from COC, and from ASCO. Okay, next slide. This is just a little picture. It's very hard to see, but our A3, what the form looks like and how we kind of broke down our problem and what we currently have going to figure out what to do. Next slide. The next one's our visual map. These big yellow things are the problems that we discovered when we were observing what we currently have. So it's what we could identify as things that we need to grow on when we're trying to change and redevelop our program. And you can kind of skip to a couple slides here. I touched on those already. So if you can skip that one, and then one more. Okay, so once we did all of our data review, our visual stream map, and we met with the other sites, we kind of wanted to pull in people from our own team to get their input at it. So we made a survivorship improvement event. We really wanted to have stakeholders who needed to be involved and provide us with new ideas. Decision makers, team members, pick out solutions that would have a high impact, low cost, and just really get to some really new creative things. Okay, next slide. At our improvement event, we had a host of people there. It was 2 oncology nurses from our hospital. Our medical director oncologist was there, myself as our navigator, Courtney as our social worker, Lisa as our nurse manager. We had 2 patients come to get patient input. We had somebody from primary care that could get an outside look into oncology without the background, and what would outsiders see as things that are needed. Patient caregivers, we had a couple of them. We also had some admin staff to have a completely way different view. So we want to put all those together to get some ideas. And next slide. We did lots of different activities. We gave them tools, taught them about flows of healthcare, wastes of healthcare, biases, and gave them some education on that, the first part of our event. The second part, we did idea generation and brainstorming, which was very simple, but actually very fun. Everybody got different color sticky notes, and we asked them to write ideas, write down problems, write down things that they see we had gaps in. Be creative as you wanted, and we put all these sticky notes up on a board, and we divided them up into different categories. So we could really see what common themes were coming up as good ideas or problems. Next slide. And then we found what our current state has for issues. We were able to really identify some like 4 solid problems. Basically, we had no dedicated staff that would educate patients on what survivorship was prior to being seen. I think it's very important for patients to know what they're being seen for and that we have a survivorship program and what is that. We had really no time frame to identify patients to receive their visit. We had patients when we were doing the visit observations, we had patients that would be seen 2 months into their cancer care, 1 year after cancer cure, 5 years after cancer cure. So it was not any kind of standard time frame. And I think that for patients to have something that we kind of repetitively do, we can learn from that and give them information and resources at the appropriate time. We also had nobody that was managing our survivorship resources, which is a job we're still working on because there's a lot of resources out there. Resources change, they need to be updated, and we really didn't have anybody doing that. And then also, we want to make sure that patients were getting those resources in a timely manner, and when is the best time to get those to patients. Next slide. And this one's just quick. It just shows how we prioritize all those sticky notes that we did find that had ideas that were workable. We wanted where that high arrow is high implementation, and we wanted it to be low cost and low time, but really make a good impact on things. Okay, next slide. So how do we put these ideas to work? We met with our nurse practitioner who currently was seeing patients, and we went through the issues we found, and we also went through what things she was doing that were really beneficial and good with the patients, and got her input on changes she'd like to see also. We also met with our 2 oncologists to review, all these ideas and what their thoughts were, because they're the providers and they're going to be ordering this for their patients. And again, we wanted them to fit the category, these ideas of change for high impact and easy to implement before we got to a proposed plan. Once we went through those, we also wanted to discuss things with our team members. Who has a scope to do this? Who has the time? Who is going to be able to do the resource updating and can take on these new tasks? And then we met with our team, oncologists, the nursing team, and proposed our plan and discussed how we are going to start to implement our plan. Next slide. So where are we today? We've kind of divided up roles as to what people are kind of taking on as tasks. We did all this studying back in mid-2019 and training, and we really implemented this program at the beginning of 2020, which, as everybody knows, has been a very challenging year for healthcare and for just the general population. So we just really needed to get started, and we wanted to have 2020 be our model year. So as we've faced those challenges, we've also been able to get through them and get to where we are today. So as a nurse navigator, my role is going to be to start a spreadsheet to track breast cancer patients. We started with breast cancer as our scope because we didn't want to get too large and include every cancer diagnosis, because it would be too large of a scope, and we really wanted to start small. And then as we found problems and good things and grew the program, we could get it out to the other cancer diagnoses. So we started with breast cancer. It had a lot of research, and it seemed like a good point to start. So as we get a new consult, I add it to the spreadsheet. I put their treatment start dates in there. Their end dates are tracked when they're seeing the oncologist. So all of that's documented and tracked, so we can look back to see what was going on with this patient. And also that helps for us to make sure that all these new patients are getting into our system. We also want to, I ensure that the oncologists are requesting a survivorship appointment at the appropriate time. As a team, we decided that to give the oncologist would give the patients their survivorship visit when they're ending active treatment, such as chemo or radiation or surgery, and then before they went on their long-term treatment, which should be surveillance or their AIs, all of that. So that's kind of the time frame that we decided on, and so I want to make sure that oncologists are doing the ordering at that time. And then also I make sure that survivorship appointment occurred. I tracked that the nurse practitioner gave a care plan to the patient, and that all of that is in the electronic medical record. Next slide, please. The third person who took a big role in this was our nurse practitioner. She did a great job with the patient. She was already making these care plans, but we just wanted to get things a little more organized and standardized for her. So I also want to make sure that she has time to create these care plans, and then she can go through them with the patient at the visit, and that she does that visit at the indicated time frame from the physicians. We want to make sure that she reviews and gives patients individualized care plans and that they get to the medical record. And also she'll schedule any follow-up survivorship visits as indicated by her, the patient. Some patients need one visit, they get their care plan and they're off. Other patients are going to need multiple follow-ups. If they have a lot of resources they need, or they need a lot of extra support, we want to make sure that she's available to see them ongoing until they feel like they can, either spread that out or get out on their own. And then we want to make sure that any supportive referrals are made by her if they're identified at any of the survivorship visits. And next slide, please. And then last would be our medical oncologists. They need to order the consult at the right time and make sure it's being done at that active treatment time when the patient's completing that. Also, patients who are not receiving chemo, we typically refer them to survivorship about 4 to 6 weeks after they start their AI. So it also could be a time where they can meet with a nurse practitioner to go over side effects, symptom management, and make sure that things are going okay on their new long-term medicine. Then we have that group of patients who just does not want to do this. They decline survivorship appointment, they decline a care plan, and we want to make sure that oncologist has offered that to them, but that they will just continue to follow with that oncologist, and the physician will assess them for ongoing needs. Next slide, please. So we already have identified work that needs to be done. At the completion of 2020, our plan is to audit effectiveness, and we're now getting towards the end of this year. We're trying to get some auditing tools developed so we know how to fix things, what needs to be done better, what's already working great and needs to be continued. So basically, the really big things we want to look at are all breast cancer patients being tracked and offered this. Is a nurse practitioner completing more survivorships per year than she was before? Are the referrals being made to the supportive services so patients get the services they need? Are the oncologists referring at the appropriate times, and are patients feeling that their survivorship needs are met? So those are going to be the big things we're looking at, and we're now currently trying to develop tools to make sure that we can assess this on the patients and providers. Next slide, please. So like I said, work still needs to be done, looking at gaps and problems. We found one thing is that patients who are on long regimens of chemotherapy, when they're on Herceptin or Progetas for many, many months, and even up to a year or more, they may need the survivorship assessment sooner because this year period of time is too long. And a lot of these patients are needing survivorship resources while they're getting their treatment. So we're going to take that population of these longer regimens and look at them separately to see what changes we need to make for them and get them into survivorship sooner. And then we really, we know this framework and the spreadsheet and all of this tracking is working really well, but now we really need to focus on getting these resources to patients, making them electronic because of COVID and having the inaccessibility at times to get into the clinic, and then maintaining these resources without a lot of waste. So our next step is to work as a team to identify solutions to some of these issues, and then look at more issues that will come out of our end of the year audit. Next slide, please. So goals to work towards is complete our year-end audit, work with our team to get new solutions, and then once our program is functioning and we've deemed it successful, we'd like to develop plans to grow the program, expand it to other cancer diagnoses such as lung, colon, head and neck, et cetera. And then also really work to continue to expand our resources and our supportive measures. I feel like that's something that is not going to end. It's going to continue to grow, needed to be updated, and that's going to be a job that's going to be ongoing. So that is where we're at. And we also, with our 6 sites, this Westfield site's the only site that has a survivorship program formally now. So we would like to get it out to our other 5 sites in Western Wisconsin, but we want to wait till we kind of have all these kinks worked out and we know which providers at the clinics are doing which roles, and make sure all of the other sites are staffed with these kind of roles so that we really have a solid program to get out to our other sites. So it's new and it's in the beginning phases for us. And like I said, we're a small hospital, so we need to start somewhere. But I feel like our first year with all of the COVID challenges has been somewhat successful, and we have a lot to grow on. So thank you.
Thank you so much, Andrea. We appreciate it. We will move to Megan with Vitas Healthcare. Megan?
Yes, good afternoon. So a lot of really great stories today about success stories we can all share and learn from, and I appreciate those that were shared. Today, I'll be speaking about comfort care as it relates to end-of-life care and discussing options related to hospice and palliative interventions. Next slide, please. I know that when we talk about hospice, oftentimes when I'm in the community, even with family caregivers and seniors, people ask, well, what is healthcare, and I describe the fact that for hospice, and they say, I hope I never need your services. I can completely appreciate that. But what I share with you today as advocates and community healthcare workers is that hope never does go away. It simply changes. Outline for my conversation today will be a little bit of discussion. I would be remiss if I didn't start with advanced care planning, talking about healthcare power of attorney, and then we'll speak a little bit about how palliative care and hospice care continue to support patients at end of life now more than ever during the pandemic, and how we've kind of adapted and improvised to continue to bring quality care and comfort interventions to those patients. With respect to advanced care planning, just from working with my own team, so important it is that we are all advocates for care conversations that really help families, people with advanced disease or no disease, have conversations with their loved ones. They can develop a sense of what they want as time would progress, as symptoms would present, and as disease might progress. We want to have conversations. We want to document wishes so that we can honor dignity and honor wishes as individuals will progress. So who should have a healthcare power of attorney document? Anyone over the age of 18 should begin in having some conversations and have a document that gives legal authority to their agent when they cannot speak for themselves. This would be something that would only be activated by two physicians that would mean that the individual would be incapacitated or incapable of making decisions on their own. I think it's important to note that we will have no guarantee of ever needing to utilize the activated power of attorney document for healthcare, but it's so important that we have this document established and then we have ongoing conversations with our loved ones and family members. I think it's important to know that different seasons of our life will call for different actions. Our values change throughout the life course. Even our agents who we might choose to make those choices for us may change. As we speak a little bit about palliative care and hospice care today, we'll be speaking about different questions that we might have as individuals and how we can advocate for ourselves, advocate for our loved ones. And the more we know, the better we can do at empowering ourselves to make informed choices. Next slide.
Megan, so sorry to interrupt. This is Sarah. You're breaking up just a little bit. I was wondering maybe if you could put your, speak a little bit. It's not always, but just a little bit here or there. Could you try again? Just breaking up a little bit.
Sarah. Yes. Top causes of death for those age 65 and older. I look at these statistics, and they're statistics that are for Medicaid age patients. But what you'll see is that the vast majority of deaths are due to chronic illness that usually have one of two courses. So first course being relatively predictable course with a rapid decline just before death, such as those with progressing in cancer, or the second course would be the slow decline punctuated by exacerbations, multiple hospitalizations. Think your cardiac patient, your COPD patient, or dementia. So cancer was the second leading cause of death for the population of 65 or over. And what we know at this point in time is that our healthcare system is very fragmented in the last year of life. And oftentimes there's very burdensome transitions for individuals utilizing the healthcare system. So multiple visits to the emergency room, ICU stays that are potentially prolonged, and multiple hospitalizations in the last 6 months of life. We know that 43% of patients had a healthcare transition in the last 2 weeks of life. So think hospital discharge to home or hospital to nursing home. 30% of patients had an ICU stay in the last month of life, and 15% of patients had 3 or more hospitalizations in the last 90 days of life. So that's an astounding burden of transitions in and out of hospital stay, and just different specialists helping to devise a care plan to meet a need. Bottom line is that people are not afforded the opportunity to live out final weeks, final months where they would choose to be, and that's generally at home surrounded by loved ones. So I again leave you with advanced care planning. So having conversations about care, wishes, and values as disease would present and progress helps empower people to have conversations with their family, with their caregivers, and most importantly with healthcare providers well before a crisis, and then documenting those wishes so that they can be honored. Next slide, please. So I think this image is one that I frequently speak to when I'm speaking with family caregivers as well as professional caregivers. It is a model of the palliative care as well as hospice. And it depicts that while all hospice is palliative in nature, not all palliative care is hospice. In the US, we lack a robust palliative care specialty for a number of reasons. In an ideal world, we would have palliative care in all hospitals, all primary care offices, and all specialty clinics. Palliative care is an approach to caring for people with a serious illness, and the goal is to relieve symptoms and stress, burdens that are related to that serious illness. We're all familiar with palliation. Think about taking an Advil for a migraine or pain relief for sore muscle. We're treating a symptom, but not necessarily treating the underlying illness. But we're trying to improve quality of life. Palliative care is appropriate at any age and at any stage of illness. It can be provided along with life-prolonging treatments. Palliative care can be provided by a primary care specialist, a specialist, a home care and healthcare provider, and there are, of course, trained palliative medicine teams. Hospice, however, provides support and care for people that are at the final stage of their life-limiting illness, and the focus is truly on quality of life rather than prolongation of life. The choice is made to stop treatments that may be ineffective or uncomfortable to the person. Hospice is well defined by our government, by Medicare, Medicaid standards, and it is covered at 100% for care related to that illness. Hospice brings comfort care to those at end of life and is focused primarily on bringing care to that person in the setting of their choice. Next slide, please. This is another image that might help explain the paradigm of hospice and palliative care. You will see how on the very left of this image, time course of illness, it might be onset of diagnosis. The individual is really focusing on curative modalities, treatment of disease. And as interventions maybe become less effective or less appropriate, we initiate palliative interventions to treat symptoms, maybe modifying different therapies and interventions. And when therapies truly prove to be no longer effective, hospice is introduced in the final months of life. I think there's a lot of myths still about what hospice provides or what hospice is and what it is not. One thing that I commonly hear in my travels is that hospice is a place that people go. It is a hospice house that they go to die. Another common myth is that hospice hastens death. I'm here to tell you that hospice brings care to people wherever they may be. We're there to bring care to meet them where they're at, whether it's the bungalow that they've lived in for their life, whether it's a assisted living building, whether it's an adult child's home, a caregiver, a friend's home. We bring care to people, and it is never our goal to hasten or expedite death. It is our goal to see dying as a very natural process, and the hospice team is there to support the journey at that point in time. Next slide, please. So eligibility, general eligibility to receive hospice care would be the individual has an incurable disease with a prognosis that's very limited, generally the last 6 months of life. Now, that's not to say that an individual could start hospice and might outlive that 6 months. We have had patients that, despite anybody's best guess, are on hospice services for far longer than 6 months. Additionally, to be eligible for hospice services, generally it's a caregiver, family member, a physician that certifies that there's a change in status. This individual has increased dependency on their daily living activities. Maybe there's some weight loss, some difficulty swallowing, increased confusion, increased sleep and disorientation. And as I had mentioned earlier, increased utilization of the healthcare system and healthcare transitions. Generally, the individual has symptoms and they're looking to treat the symptoms when there's nothing more that can be done to treat the disease. So next slide, please, is another image. I'm very visual in my thought and my explanation here, but going back to what does a goals of care conversation look like? How do we impart advanced care planning, conversations well before the crisis? We might look at this, goals of care conversations to help honor values and wishes. We look at the one bubble being survival, second being quality of life, and third being cost and burden. So generally, When an individual is exploring palliative interventions and specifically hospice, their goals might be no additional hospital stays. They might say, I've been in and out of this hospital a number of times in the last few weeks or months, and I don't want to go back. They might choose to be treating symptoms and say, I no longer want to be in the chair receiving an IV fluid for 4 hours once a week. They also may have some increased symptoms such as shortness of breath, pain, some nausea and vomiting. And they may say, I want to be home and I want to let nature take its course. At this point, these are some real tangible things that conversation has illuminated that we as advocates can help draw a care plan to help meet the needs of that person. Next slide, please. Some of the symptoms that we commonly manage as a hospice team, patients with advanced cancer typically have similar symptom burden. Yes, we think about physical symptoms, but we also know there's some depression, some isolation, some spiritual despair that present. More than 50% of hospice patients with cancer will suffer from pain, lack of energy, drowsiness, dry mouth, shortness of breath, and some depression. So next slide. Given that some of these symptoms that we are working to alleviate are not just physical symptoms, it would be very appropriate to not only have a nurse involved and physician involved in that clinical matters, but to also impart the care of a hospice social worker, a non-denominational chaplain, as well as some other important team members to help address some other things that might be going on, to really help impart quality to every day that we have to serve and bring care to this individual. Next slide, please. I have to illuminate the fact that there's 4 levels of hospice care, very well defined by Medicare. And all hospices, all licensed hospices have to offer these 4 levels of care. The level of hospice care is truly determined by the clinical need of that individual. Most commonly, individuals receive a routine level of care and a routine care plan where there's scheduled, established, expected visits throughout the week. And at any point in time, we know a condition may change. And at this point, an individual may be offered a higher level of care to meet clinical needs that might be presenting, such as terminal restlessness. At this point, we may talk about intensive comfort care in home or an inpatient unit. I think it's important to note that despite pandemic right now and many people wanting to stay isolated in home environments, many hospice teams are busier than ever, meeting the needs of bringing care to people where they are at, whether they are in assisted living and nursing home, and hospice teams are working overtime to bring elevated care to keep individuals there to prevent repeat unwanted hospitalizations. Also thinking about hospice in the home environment where somebody may be COVID positive, asymptomatic, but really wanting care at home to treat their advanced cancer. And a hospice team will be using full PPE and protection, but providing really robust care in the home so that patient no longer has to go outside to the hospital or even clinical services. There's a lot that hospice nurses, social workers, and chaplains are doing to really bring care to people safely and timely. Additionally, using the services of telehealth. So after hours nurse triage by telehealth. And I think some of the really neat things that I've seen is that where family members are not allowed in buildings where loved ones are on hospice, we have hospice social workers or nurses able to sit at the bedside with the patient with a screen and provide a FaceTime visit so they can see each other, hear each other, and have a really nice visit, face-to-face in the virtual sense. Next slide, please. I know we're up against the clock and this is such important work that you're all involved in, but as we all share the successes, I will leave you with this. I think a lot of people choose not to think about advanced stage and end of life care needs, but you matter because you are you. You matter to the last moment of life, and we will all do all that we can, not only to help you die peacefully, but also to live until the very end. Thank you so very much.
Thank you so much. We are going to quickly play Dr. LeConte's presentation. And then I think what we'll do instead of doing breakout sessions is maybe have just a little bit of a discussion at the end, or see if we have a few minutes of breakout networking. So we'll go ahead and play Dr. LeConte's presentation, and I apologize for the time. We'll keep you all abreast of the flexible agenda based on the great dialogue. Excuse us all, we're having a little bit of an issue with the sound. Dr. LeConte will be she managed to get out of clinic and will be trying to present for us live instead of doing a recording. Dr. LeConte, are you there?
Hey, Sarah?
Yes, I can hear you.
Okay. Well, we're going to do this on the fly because what the heck? I won't be able to stay for the Q&A, and I'm sorry my pre-recorded talk didn't work, but I wanted to present to you guys some recent data that we've done, and I apologize I'm wearing a mask because I'm in the hospital, so I hope you can hear me clearly. Around rural outcomes in Wisconsin. So I'm just going to walk you through several projects. I do not have any conflicts of interest to disclose, and I won't be discussing any off-label FDA uses. So first we did a project where we looked at over 1,500 pancreatic ductal adenocarcinoma patients from the UW's cancer registry to try to understand the multiple ways that researchers can measure rurality. There's several different measures that we use. One is called RUCA, which you can define by zip or census tract. One is called RUC, which stands for Rural Urban Commuting Continuum. And then one is called the Index of Relative Rurality, or IRR. And what we did with this project of 1,500 patients, which represented 84 counties in Wisconsin and 452 zip codes, was that we looked at which category each individual patient fell into by RUCA, ZIP, RUCA census tract, RUC, and IRR. And then we looked over time and across indices to see if there was a winner in terms of which one we thought performed best. Rurality was compared by the median and the interquartile range, and then we also did a visual inspection with a violin plot. This was a collaborative project with sociology, biomedical engineering, and myself in medical oncology. The upshot is that 31% of our patients did have a change in urban to rural designation despite no physical change in their address. And RUC, the measure RUC, performed the best. It's easier to obtain across all the usual data sets, and it had less change over time. And again, this one accounts for commuting. So if you're in a rural community, but you have a large community that you can easily commute to, one county over, that would mean you're not necessarily as rural of a county. And this was presented at the American Society of Clinical Oncology virtual meeting in May of this year. Next slide, please. Okay, great. So
I think we have it up.
This is a demonstration of the RUCA codes across Wisconsin, just showing you that we have several areas of quite rural distribution, but also those black areas are the most urban parts of our state. Next slide. The next project that we looked at was cancer mortality and social determinants of health. This was a companion project with Amy Trentham-Dietz and multiple investigators across the Cancer Center. We looked at counties that were defined as rural, which was defined by the root code 7 to 9, or non-rural, which was everything else. And then we applied the age-adjusted cancer-specific cancer mortality rate across all cancer sites except for non-invasive skin cancer using the state cancer registry. And then we applied the county health ranking methodology for health behaviors, clinical care, socioeconomic factors, and physical environment. Health behaviors specifically involve smoking, alcohol use, obesity, and physical activity. Clinical care involves HPV vaccination, which is a cancer prevention vaccine, breast, cervical, and colorectal screening, and then access to primary care physicians. Socioeconomic factors use the area deprivation index, which I have a little asterisk there because I wanted to make sure to mention that I find the name of that measure troublesome, and that we're focusing on deprivation and not assets, and that I think when we do community work, we're better off to focus on opportunities and assets in these communities and not deprivation, but that's a sidebar commentary from me. And then physical environment looks at food deserts, alcohol outlets, air quality, and pesticide use. Next slide, please. Great. What we found was consistent with what has been found across the country, and that is that the health ranking was associated with cancer mortality, and rural communities had worse health rankings and higher cancer mortality rates. However, health ranking categories was strongly driven by socioeconomic factors. So just to remind you, that's alcohol, tobacco, exercise, and obesity. So I would argue those are modifiable risk factors. So that's the good news. And the other good news is that rural communities did score better in physical environment factor rating. So again, that is their asset in that community. Next slide, please. And this was presented again at a national meeting this year. Then we looked at health communication preferences for rural communities. This is a side branch of the Wisconsin effort to reduce rural cancer, which is called the WIRC Committee, WIRRC, which was convened across the state, but included Carbone members. And we did a facilitated interview with 17 rural community leaders and 8 rural research partners. Interviewees were asked open-ended questions about barriers and facilitators by trained interviewers. And then we did interview transcripts and we analyzed via inductive, and deductive coding, thank you. And this was submitted for presentation at the Society of Public Health Education for this year. Next slide. What we found was that 51% of respondents prioritized knowledge increase as their key area for improvement, specifically around cancer screening and preventive behaviors. 41% also thought we could work on attitudes and perceptions, significant lack of trust in healthcare workers, but also cancer fatalism and a general fear of cancer diagnoses. 29% saw cultural opportunities, stoicism being a strong behavioral norm that came through the sort of belief that you're going to die of something, so why worry about cancer? And also a clear need for culturally humble communications around rural communities and cancer prevention. I will also note that 25% had negative experiences with research, and that another 25% felt that that contributed to a lack of interest and participation in research, which is a key area for improvement for us. Next slide. That may be my last slide. I believe this was the last topic area. Oh, no, one more area, sorry. Financial burden. So this was the Survey of the Health of Wisconsin, which is a big cohort study, goes out in the field every couple of years. We were able to tag on a survey of cancer survivors. We had 306 cancer survivors that completed this particular part, which is called the COST tool, which stands for Comprehensive Score for Financial Toxicity. That was an 81% response rate, which is considered quite high in survey work. And again, we use RUCA code. Knowing what we know now, we wish we would have used RUC code, but you can't change your methods after the fact. And here, a lower score is better. Next slide, please. I'll just give you, while we're waiting for the slide to pull up, the upshot is that every community had significant financial toxicity. So the purple line represents the actual cost score, and numerically there is a slightly higher amount in the urban core communities, but functionally it's high across the board. So almost every cancer patient, whether you're urban or rural, had financial toxicity. Our cohort tended to be in the most favorable social determinant group, so was older, white, privately insured, and female, and even that group still had significant financial toxicity. 8% of our respondents had to borrow money or go into debt due to their cancer, and 6% chose or had to forego treatment due to cost. So I would argue financial toxicity is an area for all of us to work on, rural or not. And I believe that was my last slide. Thank you for working with me while we got through the AV glitches.
Thank you so much, Dr. LaConte. We really appreciate it. So I, I think we'll actually, instead of going to our breakout sessions for today, actually just go ahead and move forward with a large group discussion. Our breakout sessions were going to be focused on the various areas of the cancer care continuum anyway, and I think our panelists have just done a phenomenal job of having, us kickstart that. So if anyone has any questions for the panelists, feel free to chime in now, or have any comments, questions, thoughts, just overall about the cancer plan. We would be happy to do that now. And Dr. LaConte mentioned that she does have to drop off and added her email.
Hi, Sarah, it's Beth. There was a question for Carol regarding the pink shawls. And if they ever had the mobile screening unit at Indian Summer. So I don't know, I don't see that it was answered in the chat. So I just wanted to ask Carol if that was a place that you had the mobile screening unit.
No, we never had it at the, we had thought about having it there, but there are registration requirements and insurance backgrounds that needed to be cleared. So unfortunately, it was an idea that we had, but never materialized. And I think it would be too cumbersome to actually have in that kind of setting. But we would have liked to, because even just to have it so people could come on board like they would do at the Coleman walk, they would, Ascension St. Mary's would have the mobile unit there so women could come on to see exactly what took place on the unit, but we never had it at the festival.
Great, thank you, Carol. We also had a question wondering how far north you go, and do you go up to the Lac de Flambeau area?
We travel the whole state. We need to be invited by the community themselves. So it's an open invitation. We will go wherever ever we're invited. And not only do we go to the health centers, we go to the senior centers, to the community centers there. Whoever wants to invite us in, we're happy to travel.
And Carol, one more for you. Does the Pink Shawl Initiative cover any other sorts of cancer? So do you discuss cervical cancer or any other type of screening?
We do, in regards to, since the Well Woman program is our supporter, we have expanded from breast cancer to cervical cancers as well. And we just, in all around, we try to encourage women just to have all screenings, throughout life, and the importance of getting screened, because many times they're not suggested to have them. So I think in the small community settings and conversations that we have, more women are apt to ask about these types of different offerings, and we hope that they seek them out.
So Carol, there was also some enthusiasm around the data that you shared on attitudes and knowledge among community members. Is that data that would be available for partners to use?
Well, that actually, I'm currently right on another conference call presentation with the Roswell Cancer Center, and they are presenting on breast cancer, and they are presenting some incredible information in regards to breast cancer. Our information is derived directly from the women that participated with us, how many women we've registered, how many have been screened from the women that we actually talk to. So it's not, it's a small amount of women that, like I said, that we've taken in over the years that we've been doing this. And it really hasn't been published for anybody's use, but this for our own use and for our funders' use. But we'd be willing to share whatever we have.
Wonderful. Thank you. We also had a comment in here. I just want to make that Deborah Neville's made about Dr. LaConte and the terminology that focuses on assets when working in communities and how key that is. So I just wanted to make that comment. So if Dr. LaConte was still on the phone and able to join us, but I thought that was an important part of the discussion and of the presentation.
Thank you so much, Beth, for jumping in there. I think, 3 hours is a long time to have you all joining us. So if any questions do come up after the fact, I recognize that I'll probably have a few questions come up later this evening. So if any questions come up, please just feel free to email any one of the staff of the Wisconsin Cancer Collaborative, and we'd be happy to relay those to our presenters. But again, thank you so much to all of our presenters on the panel. Then I think we'll just go ahead and turn it over to Dr. Stolley to set us up for tomorrow.
Great, thank you. And thank you for that robust panel. I'm sorry that we weren't able to get to the breakout rooms, but I think those panel discussions were so important. It really gave us the sense of the efforts around the state, from prevention all the way to end of life, and that cancer care continuum that we're all engaged in. So I want to say thank you for attending today. And please be sure that you have registered for day 2, okay? It is an incredible day, again, filled with great speakers and panelists, and also, most exciting, is the regional breakout sessions that will allow us to network with peers working in our region. So make sure you register, sign on tomorrow, 9 a.m. And we look forward to a great day again tomorrow. If you have any questions about anything, again, put them in the chat and we'll be keeping track of that. And we'll get back to you on those. And thank you again so much. And we'll see you again in the morning.